Hello everyone, today we'll be looking at common childhood exanthems. So here are the classical common childhood exanthems. They were named in accordance to which ones were discovered first. So measles was discovered first and it's called the first disease. Then came scarlet fever, which was called the second disease, etc., etc., etc. So now these names are not really used anymore. We use these names. So this include measles, scarlet fever, rubella, erythema infectiosum, and Roseola infantum. And here are the causative organisms. If you notice, all these are caused by viruses except for scarlet fever, which is caused by streptococcus. In specifically, group A is streptococcus, which is a bacteria. The rest is caused by virus. Chickenpox was not categorized under this because these are all appearing as macular-papular rash, while chickenpox looks totally different. Appears as vesicles, but chickenpox is also caused by a virus. So let's look at these one by one. So the first case here, we see a child, very unwell child, presenting with lethargy, fever, very high fever, about 40 degrees Celsius, um, anorexia, not really eating, you have conjunctivitis, you have coryza. Then you look into the mouth, you can see some coplic spots, which are white color spots on an erythematous background on the inside of their cheeks. On their body, you can see macular-papular rash, and when you ask the mother, it started from behind the neck, spread down behind the ears. Started from behind the ears, spread down the neck towards the trunk, then towards the rest of the bodies in the arms and legs. What is it? It's measles. So the cause is a measles. Measles virus is airborne, so it's highly contagious. Presentation is with high fever, malaise, and anorexia, very unwell. Um, with the three C's. The three C's are cough, coryza, and conjunctivitis. And then there's the pathognomonic sign of coplic spots, which we saw just now. It appears 48 hours prior to the rash. And the rash is a maculopapular blanching rash. It starts from behind the ears. It spreads cephalocaudally, which is from head towards the trunk, then centrifugal from the trunk towards the limbs. However, it spares the palms. After 3 to 4 days, this rash fades away into darker brown color. Complications is the reason why measles needs to be vaccinated against because it causes lots of mortality and morbidity in children. It causes otitis media, which can lead to deafness. It causes diarrhea, pneumonia. Pneumonia is the major cause of death in people infected with measles. CNS infections including encephalitis, acute demyelinating encephalomyelitis, and severe subacute sclerosing panencephalitis. This is a very devastating disease. The end result is death. Occurs quite long after the initial measles infection, an average of 7 to 10 years after the initial measles infection. Measles management, you need to notify the authorities, you need to isolate them in a different room in a hospital so that they don't spread the infection to other immunocompromised individuals. Investigations, you can take blood samples, you can take throat or nasopharyngeal swab, you can take urine sample to test for the virus. Treatment is only supportive. There's no cure for measles virus. They have pneumonia, you give them respiratory support, give them IV drips, and so on. Vitamin A. So this is not a treatment, but vitamin A deficiency has been shown that if you give vitamin A supplementation, it can improve morbidity and mortality in those populations which have vitamin A deficiency. And ribavirin is an antiviral. It's only given to immunocompromised individuals. Learning outcomes, you need to remember the three C's. You check inside the cheek. For coplic spots, there's a pathognomonic sign. Ask about vaccination history and contact history. Ask about where the rash started. Remember, for measles, it starts typically behind the ears, then spreads down to the trunk, spreads to the limbs. Next one is quite obvious if you've seen it before. This is chickenpox. You can see it's caused by the varicella zoster virus. It's the patient usually presents with fever, malaise, anorexia, pharyngitis, and then after that, about 24 hours later, they have an itchy pleomorphic rash. Pleo means many, morphic means forms, many forms of rash, and it comes out in crops for a duration of about 3 days. So these rashes start as macules, flat small lesions, turn into papules very rapidly. So a raised lesion, then vesicles, there's some fluid inside the raised lesion now, and then pustules, the fluid turns into pus, and then as the pus bursts and dries, forms a crust on top of the papule. So at any point of time, you can see a few of these. You can see papule, vesicle, pustule at the same time because it comes up in crops. Complications include secondary bacterial skin infection and encephalitis. And it's dangerous for pregnant women in less than 20 weeks. There's a small chance, less than 2% chance, that the child will have ocular or neurological damage or digital dysplasia. But around delivery is quite dangerous because if the pregnant mother has a high viral load during this time, the child is unprotected by the mother's immunoglobulins. Um, then they have a 25% chance. The child has a 25% chance of developing a vesicular rash, and this illness has a mortality rate as high as 30%. So chickenpox, avoid getting in contact with pregnant women so that you don't infect them. And is dangerous for immunocompromised individuals as well because they will have a more severe form of chickenpox where they can have hemorrhagic lesions, progressive disseminated infection. Management, there's symptomatic treatment. You treat the itch with calamine lotion or antihistamines. Pain control with paracetamol. This is according to NICE-CKS. They recommend that in more than 14 year olds, you can prescribe oral acyclovir 800 milligrams 5 times a day for 7 days in those presenting within 24 hours. And if there are any complications, you need to admit them. So learning points, you ask about contact history and vaccination history again. And remember, chickenpox has the typical pleomorphic rash, many forms, papules, vesicles, pustules at the same time. So after your chickenpox, what do you get? There's a dermatomal distribution of rash. It's painful. It's known as shingles. So what do you do for shingles? This according to NICE-CKS again for immunocompetent children with shingles. Antiviral treatment is not usually recommended. It's only recommended when the pain is moderate or severe, the rash is moderate or severe, the rash is not on the trunk, it's on the neck, limbs, or perineum, or the person is immunocompromised. However, they have to be stable and systemically well, otherwise, they have to be admitted. If they're systemically well, then you can give oral antiviral, which can be acyclovir or valacyclovir or famiciclovir if they present within 72 hours of the rash onset. Next case, this is a 2-year-old with low-grade fever this time. So measles has high-grade fever, this low-grade fever for 2 days. Looks like measles is another macular papular rash. It starts in the face, goes to the trunks, and then goes to the limbs in 24 hours. So there's much faster spread than measles in terms of the rash. It goes from head several caudal to centrifugal much faster than measles. It can and it's associated with lymphadenopathy, especially of the posterior auricular lymph nodes and occipital lymph nodes. So what is this? This is rubella. Presentation is they might be asymptomatic. They can only show sometimes they only have the rash without all this low-grade fever and lymphadenopathy. However, teenagers and adults are more likely to be symptomatic and sometimes associated with arthralgia, which is joint pain, especially of the knee joints, wrists, and fingers. The rash appears as pink pinpoint macular papular rash. It spreads from the face craniocaudally to then centrifugally from the trunk to the limbs, and it gets generalized within 24 hours. The rash lasts for about 3 days. So it sounds quite mild. Some asymptomatic, some mild, low-grade fever. But why do we put rubella in our vaccination schedule? Because MMR vaccine has cover for measles, mumps, and rubella. Measles, we know it kills a lot of people, but rubella seems fine. Anybody know why we are vaccinating against it? Reason is because it is dangerous if a mother gets infected. So it can cause congenital rubella syndrome if the mother gets infected in within the first 20 weeks of pregnancy. Here are some pictures. You can see some purpura, petechiae and purpura on this new neonate. You can see some what is this, cataracts in the eyes. There's some typical features of congenital rubella syndrome. Here's a table from Up to Date, which describes the manifestations of congenital rubella syndrome. So these includes hearing impairment, congenital heart defect, microcephaly, cataracts. So it affects almost every single organ in your body. Low birth weight, hepatosplenomegaly, purpura, can have mental retardation, meningoencephalitis, and so on. So it's a terrible, terrible disease if a pregnant woman gets it. The child will be born with all these defects. Link points ask about vaccination and contact history. Now this is another case. You can see in all these pictures, they look like they were slapped in their cheek. They're very erythematous rash, especially on the cheek, and it's relatively perioral sparing. And then if the body on the rash, if you inspect very closely, you can see a reticular pattern, which is sometimes they call it a lace-like rash. So what is this? This is the Erythema Infectiosum, also known as fifth disease, or some people call it slap cheek disease. It's caused by the parvovirus B19. The presentation varies from mild to severe depending on the comorbidities of the individuals, which we will look at later on. So they can appear with non-specific symptoms such as fever, headache, sore throat, nausea, and diarrhea for 2 to 5 days, followed by the slap cheek rash for a few days. Then comes the lace-like rash on the trunk and extremities, or the reticular rash. And depending on whether the patient has certain comorbidities, can be presenting as mild to severe. Usually it's mild. However, in individuals with increased red blood cell turnover, they can have something known as transient aplastic crisis, because this parvovirus destroys erythrocyte progenitor cells. They need these erythrocyte progenitor cells to become mature red blood cells, but it's being killed off. So they can have suddenly very severe and aplastic anemia. And then if this happens in utero, it can cause hydrops fetalis. And if the immunocompromised people get this parvovirus B19 infection, they can also have transient aplastic crisis, because the immune system is not strong enough to counteract the parvovirus. Hence, an exaggerated um, response occurs. Something you need to take note here is that you need to admit if there are signs of anemia. So, shortness of breath, dizziness, lethargy. So, you need to suspect this transient aplastic anemia crisis, transient aplastic crisis is happening. So, learning points, I just put this for fun. You want to remember slap cheek. You see slap cheeks. There's 5 fingers on your hand and the palm, so you can remember the fifth disease. And in Erythema Infectiosum, EI. So, A, why you slap me? Remember Erythema Infectiosum. So makes studying a bit easier to remember. Next case. This is child with high fever as well. This is like measles, about 40 degrees Celsius. 12-month-old baby boy presenting with high fever. This is the 4th day of the rash. The rash appeared, but the fever suddenly subsided. What is this? It's also a macular-papular rash. This is Roseola infantum, also known as exanthema subitum. Causes are most commonly human herpes virus 6, can also be caused by human herpes virus 7, or enteroviruses or adenovirus, parainfluenza virus type 1. Peak prevalence is between 7 and 13 months old. Presents with high fever for 3 to 5 days, usually about 3 days. And suddenly resolves abruptly, followed by a macular-papular rash, which spreads from the neck to the trunk to the face and extremities. So it kind of mimics measles. However, the thing is, the rash suddenly subsides. The fever suddenly subsides as the rash appears on day 3. And this is quite Roseola infantum. Remember, a rose is a flower. It's quite benign and self-limiting. And treatment is supportive. In contrast with measles, where there's lots of dangerous complications. So learning points, you need to ask about the fever, ask about the details of the fever. How high was the fever? So when the fever started, now still got fever or not, and when did the fever stop? So you can have your difference. You can narrow down your differentials. Case 7. This is another case of a 6-year-old boy with sore throat for 2 days. After that, after the 2 days with a history of fever and sore throat for 2 days, and then a rash appeared. It started in the armpit and groin region, spread to the trunks and extremities, and you asked him to open his mouth. You can see strawberry tongue. So what is this? This is scarlet fever. It's caused by group A strep, and specifically the erythrogenic toxin produced by this group A strep. It's common in children aged 5 to 12 years. It presents with fever and pharyngitis, followed by a sandpaper-like rash. Sandpaper-like because there's 1 to 2 cm papules, where if you feel, it feels rough, so they call it sandpaper-like rash. Spreads from the groin and armpits and then after that to the face, and at the same time you can see strawberry tongue, and then after that it spreads to the trunk and extremities. Complications include local spread, otitis media, peritonsillar abscess, sepsis, rheumatic fever 2 to 3 weeks later. If it's untreated, endocarditis is part of rheumatic fever. Treatment is with penicillin 5, also known as phenoxyl, phenoxypenicillin, something like that. Penicillin 5 QDS for 10 days. If they are allergic to penicillin, then azithromycin. Case 8, pharyngitis. It was treated. So this patient had pharyngitis. He was treated with amoxicillin 3 days ago. Then suddenly a rash appeared. So what's this? It's a drug eruption rash. This kind of pharyngitis was caused by Epstein-Barr virus, and then the doctor prescribed amoxicillin. So amoxicillin plus EBV causes this rash. It's intense and extensive cutaneous eruption occurring 2 to 10 days after starting antibiotics and resolves within a week of discontinuing antibiotic. So the learning point here is you need to ask about drug history in rash. There's another case is not in the classical childhood exanthems. However, it's quite popular as a epidemic going on every 2 to 3 years in Malaysia. This child has ulcers in the mouth, has vesicles in the hands and feet, reduced to eat his food, and has a fever of around 38 degrees Celsius for 2 days. This is a hand-foot mouth disease. They have mouth pain, throat pain, which cause them to refuse to eat. And they can have ulcer in the mouth and tongue and vesicles with an erythematous base on the hands and feet. What rash is this? It's also another common rash in Malaysia. It's dengue rash, right? You can see erythematous maculopapular erythema with some islands of white in a sea of red. However, you need to know that dengue rash, there are two types of rash. There's a febrile rash and a convalescent rash. The island of white and sea of red is the convalescent rash. Is when during the convalescent phase. In the febrile phase, you can have not everybody will have a rash, but sometimes you can have a macular or maculopapular rash, which is blunting, in contrast to the convalescent rash, which is non-blanching. And lastly, this Dr. Tin's favorite. What is this? You have conjunctivitis, you have strawberry tongue, you have a maculopapular rash, you have redness and edema of the hands and feet, which later desquamates. You can have activation of the BCG vaccine site. It's 1-year-old Asian boy, high fever for 5 days, irritable. This Kawasaki disease. And you can remember the features, and also these are the diagnostic criteria. Biodynamic crash and burn. So remember, Kawasaki is not just the disease, also the motorcycle Kawasaki, right? So imagine you ride a motorcycle and crash somewhere and you burn. So crash and burn is the mnemonic. So crash C stands for conjunctivitis, limbus sparing conjunctivitis. R stands for rash, so generalized polymorphous rash. A stands for adenopathy, specifically cervical lymphadenopathy. S stands for strawberry tongue, red mouth, pharynx, dry cracked lips. H stands for hands and feet. At first it's red and edematous, later on it desquamates at the skin of the fingers and toes. And burn stands for fever lasting 5 days or more. So the diagnosis, you need to have fever lasting 5 days or more and 4 out of 5 of the features of crash. So Kawasaki's disease is a vasculitis. It's a medium vessel vasculitis. Its etiology is unknown. It occurs in children from 6 months to 4 years of age, more common in males and Asians. It's self-limiting. However, it can cause complications if left untreated. What's the complication? Okay, later on we'll see. The pathophysiology of Kawasaki disease is that it's caused by antibody attack against your own endothelial cells, and as they damage the endothelial cells, they expose the underlying collagen, and when the collagen is exposed, it's prone to form a clot here and cause thrombosis. So it can cause a block in your blood vessels. Other than that, damage to the endothelial cells also cause fibrin deposition onto the blood vessels, and the blood vessels, um, uh, which is usually elastic and expands a little bit as blood flows through, becomes inelastic, and then the only way it can handle the pressure is through aneurysms. The blood vessels walls actually give way because of its inelasticity and can cause aneurysms to form. And these aneurysms have a chance of rupturing. So the complications include myocardial infarction if it's blocked in the coronary arteries, and coronary artery aneurysm, which we need to look out for. So investigation and treatment, the most important investigation is the echocardiogram to look for coronary artery aneurysms. And treatment is with IVIG, intravenous immunoglobulins, within the first 10 days. And this acts by competitively inhibiting the effects of your autoimmune immunoglobulins that's damaging your endothelial blood vessels, and also aspirin, ASA, which is acetylsalicylic acid, also known as aspirin. And what's the reason we give this aspirin is to prevent the thrombosis from happening and prevent myocardial infarction from happening. However, there's a risk of Rice syndrome when you give aspirin to kids. But the benefit of preventing myocardial infarction, myocardial ischemia, outweighs the risk of having Rice syndrome. And we will monitor for Rice syndrome when we give aspirin. In summary, I've talked about the classic childhood exanthems, which includes measles, scarlet fever, rubella, erythema infectiosum, if you remember A, where it slapped me, this is a slap cheek disease. Roseola, rose is quite benign. And others include chickenpox and shingles, drop eruption, hand foot mouth disease, common in Malaysia, dengue, Kawasaki disease. And here are my references. I hope this helps with your revision. Thank you for watching the video.